I'm the Managing Director at Healthcare World. And we are joined today for what I think will be a fantastic session by a whole host of interesting, exciting, and very knowledgeable individuals as we come towards the Healthcare World stage at the 50th Arab Health. I can't believe there have been 50 of them. I was working this out this morning, and having been to 15, that means I've been to 30%. So that's not a bad figure. We have today a group of individuals that includes none other than Jacqui Rock, the former Chief Commercial Officer at NHS England, now advising the health holding company in Saudi. She'll be talking along with Jodie Sinclair about the journey of females into leadership in Middle Eastern healthcare and the benefits of that. We've also got Jim Campbell, the head of workforce at the WHO, talking about the workforce crisis and the ways in which the WHO is working with health economies in the region to try and understand their workforce issues and problems. We have Rob McGough from Hill Dickinson and Graham Cookson from the Office of Health Economics, who are going to talk about one of our sessions at Healthcare World Stage, talking about the whether data and AI can provide us with the impetus we need in order to get value-based healthcare models going. Methven Forbes, who from the Fuller and Forbes Healthcare Group, the NHS, will be joining Samina Ahmad from her equivalent primary care organisation, or one of many in Dubai and M42, talking about the challenges of primary care in the region. But we're going to start with the guy who makes all this happen. Ross Williams, Event Director, Commercial Director at Informa. 15 Arab Healths down now, is it, Ross?
Yeah, 14. So get in there.
Either way,
50, thankfully.
You're looking well on it. And joining Ross in this opening session will be Girish Kumar from Knight Frank, consultant working across the health economy in Dubai. Girish, a very good morning to you. How are you doing?
Morning, Steve. Thank you for having me.
Great stuff. So I wanted to start by putting the two of you together, just from the point of view of a bit of a scene set about, firstly, the show, the event itself, and also the health economy of Dubai. I mean, Ross, 50 Arab Healths down. What are you going to be doing this year to mark that anniversary?
Well, 50 is obviously quite a significant milestone. So we'll be talking about the past of Arab Health, what's gone on over those 50 years, but we're also focusing on the future 50 years. So what's going to be happening not only at the show itself, but in healthcare in general. We'll also be celebrating 50 years of the public health system in Dubai with Dubai Health, which is exciting. And also, I believe there's 50 years of exhibitions in Dubai as well. So there's lots going on. We'll have a number of on-site activations. We have digital memory wars, those kind of things, and setting the scene of the past. What Arab Health used to look like, and then what the plans are for the future. We've got a couple of very exciting announcements that we'll be making on site, which I can't go into right now. But we've got a lot of news to announce at the show, and we're looking forward to making all those announcements.
Fantastic. And how has it changed over those 50 years? I mean, certainly, you can only personally reflect on the last 40, but how have you seen the event change in the time that you've been involved in it?
Well, I think, the growth and scale of the event has changed significantly since I've been involved, and the story goes that the first ever Arab Health was in a tent at Dubai Creek, and over the years, as Dubai has expanded and the city's expanded, and the Dubai as a global trading hub has expanded, we've grown in line with that. So whether that's new halls, however many exhibitors we've grown over those years, but I think the thing for me is the product development. We used to see these huge machines that used to be on stands, and now they're kind of getting smaller or more interactive, more interoperability stuff is coming on board. The whole digital health side of things, every company now has a digital health arm within their business, and there's a lot more focus on that. So, we've been able to launch and grow alongside what's going on in the industry. So things like our transformation zone, the Future Health Summit that we run on the Thursday morning, all of those kind of things have really grown alongside the show. And because of the interest in the region, the interest in healthcare globally, we've been able to kind of try and stay ahead of the curve with all these changes that are happening and the developments within healthcare.
I almost wonder if the fact that medical technology and the kit and equipment is getting smaller, is that not a bad thing for you as an event organizer, because people don't need a big stand anymore?
Well, people have more room for meeting areas now, which is good, so they can get more people onto the stands to look at the equipment. So
Tremendous. And from the point of view of expectation, I mean, last year was huge. What did we top out at last year in terms of visitor numbers? Because it was massive, wasn't it?
Yeah, I think it was around 50,000 unique attendees over the 4 days. So that's people coming through the door once, but when you add those people coming through over the 4 days, we were well over the 100,000 plus visits. So this year we're expecting around 60,000 unique attendees, around 3,800 exhibitors from all over the world. New countries that are coming on board every year, and new people that want to do business not only in the UAE but the region and globally as well. It's definitely become a more global show over those 14 years that we were just discussing.
So apologies are required to anybody who wants to get anywhere in Dubai at 5 o'clock in the evening over the course of that week, because it will be total gridlock.
Yes.
Always good fun. And that of course is prompting some conversations about what you do next year, isn't it? Are those firmed up yet?
So there will be announcements in regards to our plans for 26. They are very exciting. I think we'll probably leave it to the show floor and the various activations we have there to go into a little bit more detail. But we are very excited to be talking about what's going to happen, in Arab Health 2026 and the future.
It will be. I think I've got a rough idea of what you're going to be saying, and it does sound like it's going to be very, very exciting next year. Where will we be able to find that news when it's announced?
So there'll be lots of branding throughout the exhibition. So I think we're making a couple of announcements, one on day 2, one on day 3 as well. So as soon as those announcements kind of get made, there'll be relevant updates to the materials on the show floor. So it's just watch this space, I would say. So
Girish, coming to you, all of this, of course, is set against a very lively Dubai and UAE healthcare system. As Arab Health 50 takes place, what's the background in terms of what's going on around the Dubai and UAE health economy?
Right. Let me try and summarize this for you, Steve. So the thing is, Dubai's or UAE in general, the health economy has always been a private sector dominated market, right? So that's essentially going to continue because the regulators are now sort of taking a step back. They're trying to just be regulators and just let the operators do their job. So that sector, the private sector, is essentially expected to grow twofold in terms of, the investments. And then there's also been a shift in the type of investors which are coming to the market. We see a lot more interest coming in from countries like Russia, China, and even South Korea for investors who want to come in and set up something in Dubai, because this has become the hub for medical tourism now. Not for all of it, but at least for the MENA region, Dubai is the hub. So we see a lot more maturity in the market, and plus there's an increased focus of shifting towards preventive health and wellness in the market, because that's where the government wants to sort of invest in. They want to reduce the burden. I mean, if you look at UAE in general, we're talking about 11% of diabetes, 26% obesity. These are big numbers, right? So the government's focus is that they want to implement more preventive mechanisms to reduce the burden going forward. And then the last bit is the elderly care. I mean, because there is this rising volume of seniors in this city and the country, there's a strong focus which we expect to shift towards elderly care right now.
Mm-hmm. And how is that? I mean, Ross, from your point of view, how is the event reflecting those things that are going on? I mean, Girish mentioned investment, for example. You've got quite a focus on that.
Yeah, we have a specific investment forum run alongside the exhibition this year. It's something that we've been speaking about for a little while, but I think, as Girish said, the more and more this gets talked about in general, the more we want to focus in on Arab Health. So we have added to our content program for this year.
The other thing Girish mentioned that sounds like it's reflected in the show is the move towards having that public sector provider. You mentioned you've got a number of things going on with Health Dubai. What have you got happening there?
Well, so it's a special invitation only gala dinner that they'll be hosting, but we're co-hosting it, I guess, for some special invited guests, just to celebrate that 50 years of Arab Health. and the 50 years of the public health in Dubai as well. So it's nice. It's a nice tie-in for both of us to work together and obviously celebrate both elements.
Outstanding. And Girish, coming back to you, I mean, so this is the 50th Arab Health, and I don't expect you to reflect on all 50 years that have run up to this, but you've been in that economy for a wee while now. How have you seen the health economy of Dubai change in the time that you've been there?
I mean, it's been a massive shift, right, Steve? I mean, one of the most important bit of Dubai's change has been the mandatory health insurance, right? I mean, it was implemented 10 years back. In 2024, we have the 10th year anniversary of that as well. So now that what that does is it provides people unrestricted access to healthcare. There's ease of access. If you look at Dubai 2023 data suggests there are 50 plus hospitals, 2,000 plus outpatient facilities. So what that does is Dubai has access to healthcare. Everyone can get quality of life, like we spoke about earlier. So that has been one of the major shifts that I've seen in Dubai. And what this also does is that it has brought in people looking, especially from medical tourism point, they're looking more at complex surgeries now. I mean, Dubai was previously known as a center where you would come for aesthetic treatments, dental services. But today, people are coming in for more complex procedures, orthopedic, neurosurgery, including gene therapy. We've had some remarkable cases last year in gene therapy as well. So these are the major shifts that I've seen in Dubai as a whole. And then in terms of digital health adoption, the Nabit platform has been rolled out. It provides patients with sort of control of their data and whom they can share it with. And operators are now able to sort of have a uniform platform where they can get all sort of patient data. So there's a whole shift towards more informed decision making in healthcare.
How much has the I'd say the emergence of competitive health economies? Obviously, the Saudis are going through a huge transformation program, which will make them a dominant player in the region. Abu Dhabi as well, with Pure Health, and we've got Samina with us from M42. Yeah, how much has the competition around the region changed things in terms of the way Dubai does its healthcare?
I don't think it has changed much, Steve. I mean, Dubai has always been ahead of the curve in terms of, implementing certain healthcare policies and procedures. So it's not been very different. It's still there right up in the competition. Yes, you do have the competition coming in from Saudi and Abu Dhabi. But I think there's a lot more complementing services as well because people, especially Dubai and Abu Dhabi, they do tend to have patients who keep traveling between these cities. So I don't see a lot changing there.
And for us, I guess, from your point of view, we've also seen some major events starting to pick up around the region as well. Has that affected your thinking and affected your hard work in terms of keeping Arab Health as the premier event?
No, I think it's good for people to be aware of what's happening in the region. I think the show in Abu Dhabi, as an example, is very much kind of owned by Department of Health in Abu Dhabi, and there's a slightly different focus to Arab Health, whereas Arab Health is very all-encompassing, I guess I would say, and we have different product sectors for the different companies. There's the focus on the Abu Dhabi event is I think more tailored for what's going on in Abu Dhabi right now, whereas we're definitely more globally focused, I would say. So it's nice to have that competition, and it was actually a very good event. So it was good to see what they're doing over there.
And of course, as informer, you're involved in global health in Saudi anyway. How do you see the difference between that event and what you've got in Dubai?
Well, I think both events are, the scale of the global health exhibition in Saudi now is growing exponentially year on year. There's lots of interest from our companies to participate, and it's great for the region. Companies who want to come from abroad to invest and to export to the Middle East is great for us.
And I guess, my final question for this segment before we move on to our next guest: what's new this year? What have you got happening this year that we've not seen before at Arab?
Well, so as always, the exhibition space has grown. So we've added the Al Mustaqbal Hall, which is across the way from the Novotel. So we'll have a number of exhibitors in there from different products and sectors. We also have the Ecosphere, which is a new content space where we have our healthcare ESG sessions, and we also have our was it World of Wellness as well? Sorry. So along with that, we have the investment summit that I mentioned earlier. We have our Empower Her conference sessions as well, and some non-CME business forums. So there's lots going on, lots of new things to look at, lots of new exhibitors from all over the world. So as always, we're growing. So there's lots more to see.
And of course, returning for its second year this year is the Healthcare World Stage. So
yes, of course,
we'll be doing. I think we're doing the Wednesday. We've got a packed day of content on Wednesday, some of which we'll preview now. Before we move on, last word for you, Girish. Where do you see, for those individuals and organisations coming in from the UK, Europe, US, and across the world, where do you see the major areas of opportunity at Arab Health that people should be thinking about?
I think we should be exploring more life science products, because that's where we've seen interest in. There's going to be a lot more R&D. There's funds allocated by Abu Dhabi for that, and we see a lot more of that growth. And the other bit is operators who are looking to invest in UAE should also probably start looking at Northern Emirates, because they finally rolled out the mandatory health insurance across UAE, which essentially provides a lot more opportunity for new players to come into the market in Northern Emirates, especially.
Ross, Girish, thank you very much for your time. We're gonna move on now. We've got quite a lot to get through before 11:30 and some fantastic guests. I mentioned there that the Healthcare World Stage is returning for its second year this year, and you can sign up and register for a place there on the Arab Health website and on the Healthcare World site. You do have to register to get in and get a place on that stage. And we'll be doing a whole bunch of really interesting sessions and really interesting content. We're also going to be doing a session on the main stage as part of the Empower Her element of the conference, which is an element of the conference talking about women's health and issues around women's health. Something that on a personal level I'm really passionate about. If you pick up the magazine that will be available at the entrances to Arab Health, you'll see my column specifically is talking this month about female leadership in healthcare and the importance of female leadership, particularly in Middle Eastern healthcare. And it's interesting, we had a bit of a debate before I wrote that piece about whether I, as a white middle-class male, am the right person to be talking about stuff like that. And frankly, for me, I think it's actually quite important that we see male voices speaking up to support women in healthcare. God knows we see enough male voices around the world these days that are disparaging on issues of race and sexuality, etc. So that's one of the reasons I chose to do it. And one of the reasons that I chose to put together a panel, which quite frankly I'm enormously proud of, speaking not about the issues of women's health specifically, but speaking about female leadership and the effects of diversity in decision making. And to speak about that with me now, I've got two absolutely amazing female leaders, both originally from the UK. Jacqui, of course, having risen to a very, very senior position at NHS England and now a leader in the Middle Eastern health economy, and Jodie, who is a senior partner at a major London law firm. Jacqui, I want to start with you. Arrived in Riyadh on Boxing Day, I think, with suitcases and golf clubs, and probably a Christmas hangover. The newest entrant, I guess, to the top table of senior leaders in the Middle East. How are you finding it, and what are your reflections on I guess, female leadership in the region, and indeed your own journey to getting to this point?
Yeah, thanks. That's right. We literally hosted a big Christmas day, and then just sort of got up very early in the morning and left everyone to the mess and the clearing up. So and came over to Riyadh to be part of the Saudi healthcare transformation here. And a lot of people ask me, why did I do that? Because obviously I'm very passionate about the NHS, continue to be passionate about the NHS. It's an organisation that's looking after my elderly mother, my grandchildren, and I'll be going back and it'll be looking after me at some stage in my life. But when I was looking out about opportunities for real transformation, innovation of healthcare across the globe, it was very obvious to me. I kept coming back to the Middle East, and I particularly kept coming back to the Kingdom of Saudi Arabia. In terms of the targets that they have in Saudi, and most of you will be aware of Vision 2030, which is the Crown Prince's vision for how we're basically going to diversify from oil into all other areas. So it's a really, really exciting country and region to be in right now. And healthcare is one of those major pillars in that transformation. And, you know, the kingdom's going through, like everybody else is, an aging population, complex demographics, unhealthy lifestyles, increased chronic conditions. But again, they are looking and leveraging, like we all are globally, medical innovations, devices, AI, digital therapeutics, and just the overwhelming speed and pace of all the advances in clinical pathways so far. So, you know, this is one of the reasons why I came and joined. The Health Holding Co. is a new company that's been set up by the Ministry of Health, and it is part of a very, very large transformation, which would take me about 50 minutes to even just start scraping the surface with you all. Have a look, it's very exciting. But I'm absolutely delighted to be here, and as a female, very senior leader, I could not have been more welcomed.
I mean, that's an interesting point, isn't it? I think to a lot of people around the world who've not experienced what is the modern Saudi Arabia, particularly the way in which Saudi Arabia and the kingdom has changed in the last 5 or 6 years, I think there's a lot of people out there who would probably be quite surprised to see a woman in a senior leadership position in Riyadh. Did that opportunity to kind of break down barriers and be part of that new diverse Saudi, did that play a role in your decision to take on this job?
Yeah, absolutely. And you know, I've been to the Middle East many times in my career. Never actually worked out here. And I've worked in other countries across the globe, America and India, etc., and had lots of time, but never really, you know, considered the Middle East. But I think the pace of change that is happening here, yeah, everybody I speak to, everybody, Saudis, international, it feels very different than it did 10 years ago. Incredibly different. The pace has been unbelievable. And therefore that has opened up opportunities for women, not only Saudi women, who, bear in mind, are incredibly educated, and incredibly sophisticated, wonderful population of women. I'm absolutely delighted to be getting to know many of them in very senior leadership positions, but right the way through, you know, open up the workplace to women at all levels and in all sectors. And that's really, really important. So there were always senior women, you know, from a sort of clinical pathway in the kingdom, but we're seeing more and more of it now. And that is why that did actually influence my decision to come, because I want to be part of that as well. I want to be part of the entire kingdom's transformation, not just in healthcare, but in culture, and just, yeah, because I think they're going to be a real force to be reckoned with.
There is very definitely a buzz around the country, and a huge amount of support from its population in terms of the changes and the things that are happening across the country. I want to move on to you, Jodie. I mean, we're talking here about Arab Health turning 50. And I know that, again, as I said before, I'm not expecting you to reflect on the last 50 years. It would be impossible in your case, I'm sure. But, you know, in terms of the time that you've been active in healthcare, how have you seen attitudes towards women in senior leadership positions in healthcare change?
Thanks, Steve. And hello, everybody. Delighted to be here also. So I have specialised in healthcare and predominantly on the workforce front for nearly 25 years. So I think there's been some great change. And I think if we look to other sectors, we are continuing to see an increase in female leadership and roles. And that has been largely driven by targets and objectives being set in terms of the FTSE 150 and the FTSE 350. I think, you know, one of the challenges, and you'll probably come to this in the next question, is we're still seeing men in those CEO roles, though, and quite a lot more women on the NED side. But you know, in the time that I've been going to Arab Health, and I'm still a novice because I'm only on to my, I think, 8th year, rather than the rest of you who are in double digits. You know, there are certainly more women attending as delegates. There are more women on panels. And, you know, driving that diversity agenda. But it's not just the gender diversity that brings different perspectives and learning. It is diversity across lots and lots of different sort of demographics, whether that's social, whether that's ethnic, whether that's people with disabilities, for example, but definitely more present, and definitely, as Jacqui said, more of a voice, and we're starting to hear that. And I think, you know, in the differences is obviously there's lots of cultural differences, whether it's looking at the UK, whether it's looking at the Middle East, whether it's looking at globally, in terms of some of those considerations that need to be taken into account.
I mean, the argument is there, and I think it's clear and obvious, you know, in what you were just talking about, that, you know, in order to properly represent the populations of patients and individuals that access healthcare, we need to ensure that female voices, and indeed voices from other minority, well, not female is not a minority, it's, you know, it's 50% of the population, but also having voices from minorities involved in leadership in healthcare. Only then can we truly represent the patient populations that we're looking to service. And Jacqui, I come back to you on this point. You know, I asked you whether, you know, the opportunity to be a female leader in Saudi Arabian healthcare influenced your decision to go there. Do you think equally that, you know, that there was thought given to ensuring that a senior female voice was involved in developing the policy and strategy for the healthcare provision of Saudi Arabia played any role in the health holding company's decision to appoint you?
A really good question. I think they appointed me because I was the best person for the job.
I'm sure there's no doubt.
Regardless of, I hope so anyway, regardless of my gender. I really hope so. But of course, yeah, the reason it's a really good question, Stephen, is because it's not actually been a topic of conversation. Diversity in leadership, and, you know, we've got a lot of international people in, so it's definitely there. But actually, I can, you know, the people that I'm working with now, the brilliant people that I'm working with now, it's and that's not to say that we've cracked it, but it's almost, I do hope it's been deliberate, but it hasn't had to be forced deliberate. I think it's just part of who is the best person for the job in this leadership role. So, but that's not to say that there is an absolute benefit in being very, because I'm a great believer, if you're going to put things, you know, diversity, true diversity into leadership does need to be very thought through. It does need to be deliberate. It does need to be actual activated, as opposed to just a tick box exercise and this is our attention. So yeah, it's kind of, as I said, from my perspective, it hasn't been a really sort of talked about, targeted ambition, and yet it's being realised in just the people that are coming into the organisation.
I think there's a wonderful point there that, and I can't remember where I heard this quote from, but, you know, an issue, a divisive issue, is no longer a divisive issue when people no longer have to talk about it, which I think is a wonderful thought. But Jodie, coming across to you, I mean, we're spending a lot of time. There's a whole track associated with this at Arab Health this year, talking about the lack of focus, the lack of funding, the lack of research, and the lack of knowledge we have around women's health issues. And my question really to both of you is that, you know, if we had the levels of female leadership, the levels of leadership right at the top of healthcare providers, governments, regulators, organisations over the 50 years that Arab Health has been around, would we still be talking about a lack of focus on women's health, or would that automatically have figured itself out?
I think we'd have greater parity, because I think, you know, there are lots and lots of studies, and I'm looking forward to getting into that in a bit more detail at the actual panel we're doing at Arab Health. But there's a huge number of statistics around funding for research, allocation to treatment, development of treatment, which is very geared to the male gender, unfortunately, although we are seeing change. I think having that greater equity on boards and in leadership, you know, it just drives, I think, more interesting innovation. It's greater parity around decisions. There's huge economic benefits. I mean, certainly there are reports that those boards that had greater levels of female representation during COVID outperformed their peers. And, why is that? And I think particularly in not just the Middle East, but globally, historically, women have played a massive role in being the decision makers in their own families, the impact of health. So they actually do look at things differently. And I think, to your question, Steve, whether it's preventative medicine, population health, economic benefits, training, access, I think the art of the possible, and we're getting there, but there is still more to be done. And certainly in my own role as the senior partner at Bevan Britain and working and supporting numerous boards across both the NHS and independent sector, I can remember being part of a network and having allies 25, 30 years ago. And a great thing that I still say to my peers and juniors coming up, lift as you climb. And, whether or not that's men or women, and finding that talent and fostering that talent, because, as Jacqui knows, and I know, and Graham will know, you just don't pluck those leaders out of nowhere. It's through having those allies and mentors and opportunities, and actually being able to think differently.
There's a really good point there that Jacqui made the point quite correctly, that she's in the position that she's in because she's the best person for the job. But how did you get to be the best person for the job? How were you pushed and promoted by your peers? How did you push yourself from an educational point of view, and did you have the opportunities? And I guess that's a good point at which to ask both of you, just very quickly, to share your personal journeys to how you got to where you are today. So Jacqui, for you, it's been a long road to the Health Holding Company. I think your story is particularly fascinating, given some of the amazing things that you've done, and also where you came from. Do you want to just give us a quick insight into your journey?
I will, and I'll try to keep it brief. So I was investment banking for almost 30 years, an accountant by trade, and a banker. I started off my career doing Eurobond trading. So any of us that are sort of 80s, 70s and 80s people, I don't mean as in age, I mean as in young people during that period, will know what I'm talking about. So and I had a brilliant career in investment banking, thoroughly enjoyed it, and never actually considered coming into public sector. And that often is the way that, if you have a career in the private sector, you stay in there. And it was about sort of 10 years ago that you have to be careful of the British government, because once they start asking you to be on think tanks and alumni and groups like this, before you know it, they've got their hooks into you. So I did actually join the Ministry of Defence as the Chief Commercial Officer over at Defence, and it was, I think, within about 3 or 4 weeks, I thought, well, I'm in trouble now. How am I ever going to go back to financial services? Because this is so exciting. And, as a woman, I think my first week going into a room of sort of 30, 40 senior generals, because I had a very senior position there, all in camo, all looking around at me with a bit sort of open mouthed, kind of what has just walked in the room, was a really, really fun experience. I just thought, I'm going to really enjoy it here. And so that was how I got into government. And then I got into health really briefly because of COVID. I was asked by the Prime Minister and asked by the Secretary of State for Health if I would go across and obviously help the efforts, the country's efforts, the fight against COVID. And that is how I set up the test and trace functionality with the Baroness Dido Harding. So that was my first, and so most of the time it's very, very deliberate. Every career step I've taken and everything I do, COVID kind of threw me an interesting opportunity to get into health. And once I got into health, and I had to learn very quickly, I realized just there is so much to do, not just in the UK, but just globally. And there are so many opportunities. And here I am, and here I intend to stay.
But also, I mean, I know you well enough to know that you also came from quite an underprivileged background, didn't you? You didn't have the easiest start in life. Do you want to just mention that briefly?
Correct. Yeah. It's I've got my posh voice on now, but if you could hear me with my friends, real East End. I loved my upbringing, actually. But it was pretty. Didn't go to great schools, didn't have very good opportunities. But I always, no one actually drove me to do anything. I just always had that. I think it's that inner passion, that inner sort of burning that I'm going to make something. I'm going to do something of my life. I'd like to sort of say I was like Dick Whittington and I went off to the golden streets of London, but all I had to do was jump on the tube 2 stops to get into the city, and get a job like that. And it's that's been the story. And obviously qualifications all came later. They didn't come straight out of school. I haven't got a university. I didn't go to university. You know, a lot of people didn't back in the early 80s. But you know, it really was, certainly from the school I went to, university was for the privileged. It wasn't for normal, you know, London toe rags like me, right? So we just it's all there. I've always said this. Everyone I coach, regardless of your background and your upbringing, you know, if you've got the passion, if you've got the dedication, and I work very, very hard. I've always worked very hard. You could become anything.
Yeah, and from that point of view, Jacqui, I've got a personal reflection on that. This time last year, you were at Arab Health with me in your position with NHS England, and we went out to dinner, and I had my then 18-year-old daughter with me. I don't know if you remember, and I think that, you know, from a personal point of view, that whole point around Jodie's point around lifting and supporting the people around you, you were inspirational. To my daughter Anya, you had spent a bit of time with her talking about your journey, and you know, she's now in her first year of her master's degree in pharmacy. So on a personal level, Jacqui, thank you very much for taking that time. Jodie, from your point of view, we've got to move on. The trouble is, I could talk about this topic all day. Jodie, do you want to just give us a quick insight into your journey? Obviously, coming from literally halfway around the world to your current position.
Yeah, no, sure. And very, very similar. You know, I was the first generation of my family to go to university. Both of my parents were, you know, my dad was a shearer and my mum cleaned motel rooms. So I didn't go to the private school or do any of that, and turned up in the UK in 1996, which I think I knew 2 people from university. So started my career as a locum in local authority, but found Bevan Britain and found health and found that passion back in 2000. And you know, it's similar to the things that Jacqui's talked about. It's having the passion, it's stepping into the fear, it's understanding and ignoring the imposter syndrome, it's giving it a go and step forward, and actually accepting the fact that there will be steps back. But you know, workforce and healthcare for me, I mean, it just runs deep in my veins, and I think that there is so much to do. And, you know, I say to people when I have to do briefings to our new recruits or people I coach, or in the Q&A sessions, you know, never be fearful of asking the question. And fear is okay, because actually that's where you find bravery and resilience, and innovation. And, you know, I love the fact that I'm the first generation of my family to go to university. I love the fact that I'm a role model as I lift and climb with others. So yeah, looking forward to this panel in 2 weeks' time. So there'll be more to talk about then, Steve.
And I think there will be more opportunities for you to inspire a younger generation of female leaders. I talked about Jacqui inspiring. I hope that we'll have lots of young women in the audience to be inspired by your examples. Jodie, you also talked about your passion for workforce, and I wonder if you wouldn't mind hanging on for a little while. We've got Jim Campbell, the head of workforce at the WHO, later on in the session, and if you'd be happy to, perhaps you could join Jim and myself for that segment of this morning's session. But before we get to that, another one of the sessions that we're doing on the Healthcare World stage that I'm particularly passionate about is our session on the use of AI and data in the development of value-based healthcare models. And as anybody who's followed the Healthcare World series, the Health Beats podcast, any of the stuff that I do on healthcare around the world will know, I'm fascinated and curious and very enthusiastic about the need to change the ways in which we pay for healthcare. And value-based healthcare, as I discussed actually with Jim during the podcast interview that I did with him yesterday, is not something that might happen. It's not something that is optional. It's something that has to happen. However, we are struggling to crack the nut of understanding how to put it into practice. I spoke some time ago now with Rizwan Tufail, the head of data at Pure Health in Abu Dhabi. who proposed to me the idea of doing a session at Arab Health that talked about whether data and AI could provide the solution to getting value-based healthcare off the ground in a really sensible way. Unfortunately, Rizwan was due to join us today, but it's been called away. But I still have two fascinating experts on this topic. Graham Cookson is the Chief Exec of the Office of Health Economists. Rob Le Goff, as well as a partner at Hill Dickinson, is it Vice Chair or
Vice
Chair?
President. Vice President.
Vice President of the United States.
Sounds very
No,
grand.
that's not right. That's not right. Yeah, Vice President of the European Association for Value-Based Care. I'll start with you, Rob. I mean, obviously, as Vice President of the association, you must spend some time thinking about this and ways in which we can implement. Has the question of how we can use technology, or whether technology is the key to unlocking value-based care, is that something that you've considered? Is that something you've thought about? How important do you think that is?
Honestly, it's a great question, and actually, absolutely, it has been at the forefront, I'd say, of development of value-based models, particularly over the last 2-3 years. I'm unfortunately old enough to have been around when we were talking around developing value-based healthcare models around a decade ago or more, and we were talking around a lot of the way that we would measure the outcomes and try and measure value would be involving patient questionnaires and trying to get data, and then you would have effectively be feeding information back in 6 months, a year on the outcome later than the outcome had actually taken place, to try and assess, analyze, and change the payment structures, which wasn't really a very optimal model. So the advent of data and AI has had a huge influence on the value-based healthcare implementation models that we're seeing. It has accelerated it, I think, in a way that it's exponentially each year. The opportunities appear to be growing, different providers, different ways of attempting to introduce value-based approaches. And you can see this globally in terms of, if you look at I'll give examples of it in Europe. I mean, there's huge programs in France, Germany are starting to look at it, in the Nordics, in Spain, around implementation of value-based healthcare models. And a lot of this is being driven by the access to data, being able to get the data quickly, almost live, as you're working through, to be able to see what the impacts are of how you're actually providing healthcare and the outcomes that are coming to patients from that. So it's making a huge difference. And with the layer of AI on top of the data capacity that we're starting to see, predictive modeling for risk stratification, for waiting lists. That's all starting to come into play, and that also is a game changer in terms of the ability of systems to be able to actually introduce technical changes to actually try and, if you like, optimize the outcomes that you can get within the resources that you have. So I would say, yeah, it's a very, very long answer to your question, Steve, but I would say absolutely that data and AI we're seeing having a huge impact, I would say, on the ability to start to look at a more value-based approach. Now, we don't always call it value-based healthcare. Quite often people don't even, but you can see it's the principles of what we're doing in terms of optimizing the use of the resources that we have to get that best possible outcome. That is definitely the way that healthcare systems are starting to move through the use of this technology.
I think the point needs to be made that certainly where Middle Eastern healthcare systems and the UAE specifically are concerned, and indeed the development of the payer model through the CNHI in Saudi Arabia, what we're talking about in all of those systems is very cleanly, sensibly, and clearly a system of moving away from volume-based payment models, i.e., I perform an intervention, I do a thing, and I get paid for doing that thing, which of course has the whole issue of disincentive around providers doing perhaps more than they need to because they get paid more the more that they do, and moving towards outcome-based payment models. So, basically, I get paid if somebody gets the right healthcare outcome. I think the issue for me, and apologies that this is possibly the longest question in the world, having spent a great deal of time in the Middle East. I mean, I spoke to one particular revenue cycle management consultant not 3 months ago who turned around to me, Steve, and said, I saw you on stage talking about value-based healthcare. Why does everybody talk on and on about value-based healthcare? It doesn't work. It's not happening in our systems. RCM is still an enormously large industry. Outsourcing of medical coding to companies across India for the UAE is massively commonplace. It's not there at the coalface, Steve. And there is a question coming, I promise. Graham, this is to you as the health economist in the room. Is one of the reasons why my frustrated RCM colleague is complaining about a lack of value-based healthcare at the coalface, because we've got some enormously difficult sums to do. How hard is the maths that we need to do in order to map payments, pounds, shillings and pence, dirhams, reals, to a healthcare outcome?
Well, I'm going to give a flippant answer, which is not very. So, so it's probably not what you want to hear, but and probably doing us out of a job. But the actual calculations are pretty straightforward, right? The maths involved, the econometrics, that stuff is easy. It's everything else that's hard. It's before we get to doing the sum. So on the one hand, it's the optimal design of the contract and the incentives. Are we talking about the right thing? Are we measuring the right thing? It's the design then of the outcomes-based payment system, the tariffs and the rewards. Are we getting that right? And then, yes, it's about the timely and robust collection of data. I think Rob talked quite elegantly there about how AI and new data systems and platforms are going to speed that up. But it's those first two steps that we're still away on, and we really need to reset what we mean by value. And I'd say in that very specific case, we don't agree on what value is, because if you've got a system set up that is paying for service, that is paying for doing a procedure or some level of activity, then that is not a value-based system. Even if you try and rationally allocate resources to maybe higher value outcomes, fundamentally your system is not value-based. And we have this kind of Peter Drucker axiom, right? What gets measured gets managed, and it's become a kind of philosophy among people with MBAs, I think. But as an economist, what we see is just simply kind of dysfunctional, unintended consequences of that behavior, because you end up measuring something that you can measure, not what you actually want. And that's where data will help us. It will help us move away from perhaps intermediate outcomes to that final outcomes. And what I'm kind of excited about is how potentially, without even realizing, we'll be able to measure the outcomes of healthcare in terms of my well-being day to day, how I'm living my life, my ability to go back to work, to be productive, to manage my chronic condition, all these things in new ways. And that's, I think, where the excitement comes. So yeah, we need a fundamental shift in what we mean by value.
So I can't help but just fly back to that and say, well, what do you mean by value?
Well, okay, really simple. What we need to stop doing, and every healthcare system in the world does this, and it's the worst thing. We see expenditure on health as a cost. It's not. It's an investment. The most fundamental thing we have for our economies is human capital. It's the people that go out and do work, invent new things. All this is about our human capital, our health. And so health equals wealth. And what we need to do is to reset and say it's not a cost and it's investment. And then health systems need to transition and say the objective of a healthcare system is not to treat ill people. It is to maximize and maintain the health of our population so we can all go out and be more prosperous and happier. So it's that shift. And then fundamental to that is what we're now seeing people actually talk about, which is exciting, which is the shift, a transition from kind of an illness healthcare system to a preventative well-being based system. And I totally agree with that. But at the minute, we're at the stage of talking in very nice language about it, and we're still very far away from doing it.
So Rob, pushing this one over to you, that's well and good. We want to move from sick care to healthcare is the phrase that I hear on a regular basis. We want to talk about prevention. We want to talk about healthcare as an investment in our population. But how does that translate into an insurance-based health system where you have corporate insurers, organizations who are set up by their very nature to be a function of something goes wrong, we'll pay to put it right. If nothing goes wrong, we don't want to pay for anything. How do we square the circle between the two?
It's quite. Firstly, I'd just like to agree 100% with how Graham's just described value as well, which is
I
a
mean, how can you
cultural
not? It was a
shift.
great description.
It's absolutely nailed it. So we should record that and just reuse that, Graham, again. But on the insurance side, it's an interesting debate, Steve, because I'm debating this with a number of insurance companies, both in the UK, international ones as well, and they are seeing what's coming down broadly. What Graham and I have just been discussing, they are seeing this coming downstream. They're seeing increased costs from healthcare that they're having to pay out all the time to all of these healthcare organizations because it's based on costs. You've got the American model whereby everything is itemized, huge costs sucking in terms of the way it's working, and it's very, very much then a pure economic transaction. And they see that the end game for this is that costs are just unmanageable. They're trying to manage them with the providers, but it's a huge problem for them. And then the premiums are going up, and then people are not able to afford the premiums, and then the insurance companies are starting to get into real trouble. So that they are seeing value-based healthcare and adopting value-based healthcare models with their providers as being a route under which actually they can start to, and part of that, and it's interesting, you look at Vitality in the UK, have got quite a bit of this. There's a number of other insurance companies are starting to do pretty well what Graham has just described in terms of actually we're about well-being, we're about your health, we want to keep you healthy, so we'll start incentivizing you to. So it's changing the contract with the population in terms of you look after yourself, you do these good things, your healthcare premium will be managed, and we'll start to keep, we can keep your premiums down if you're looking after yourself. That's fine. And it's that change, and the insurance companies have realized that the current system is as unsustainable in the long term. And I think that's again coming into then they want the data, or the analysis, so that they can start to model and predict forward as well. So insurance-based systems are as interested, if not more interested at the moment, in value-based healthcare as public-funded systems, Steve.
Are they interested though, or are they paying lip service to the model? I mean, and the reason I say that is because, I talk to, off the record, obviously, to insurers across the Middle East, across the US, in some of those insurance-dominated systems. And the answer I get is, well, here we are as one of a number of insurers that are competing with each other. We don't want to share data with each other because we see that as customer data. And that, Graham talked about fundamental shifts in the way that we think about these things. One thing is this is not customer data. These are patients, these are people. But, insurance companies at the moment not thinking like that, or at least they might be saying so publicly, what they're saying privately is something different. By the same token, you've also got a situation where I've heard senior executives at insurance companies turn around to me and say, Steve, why would I pay for public health intervention? Why would I pay for
the US scenario where why would they start paying for public health care because they don't have to?
It's more fundamental than that. They're turning around to me and saying that the average lifespan that I have of a customer in my program is 2.5 years. So actually, if I pay for prevention, all I'm doing is saving my competitor money. How do we? And this is to both of you, which are the answers to this. How do we change that mindset? Because to me, that seems, if we're really going to get value-based payment models going, we have to change that mindset. Graham, I can see you nodding. Do you want to?
So a couple of thoughts related to the other bit as well. I think just to start off with, I think it's a bit of a misnomer that public-based systems are thinking and are better at value-based healthcare than the insured based market. And one of the fundamental problems is, and this will be probably controversial, is that we seem to think that integration is the answer to so many things. So we go, there's an incentive incompatibility problem, and there's a difference between primary care and secondary care, and etc. And so we integrate this system and we solve the problem. And you don't, you've just put all the problem inside one box instead of it being separate boxes, right? You haven't fundamentally solved the problem. And so I don't really see them as that different between an insurance-based system and a publicly funded system, to say like the NHS or a social insurance system. But then on this kind of question, I think we are seeing some changes. So we've just done some work about workplace prevention, and actually the big role for employers to start helping improve and protect the health of their workforce. And that should be self-interested, because if my staff aren't sick, they're working, producing output, earning me money. Rob's billing more billable hours. I'm doing more stuff. And that's important. And I think in many insurance-based systems, there is a connection between insurance through employment. And so what I think we need to see is a greater conversation between employers and insurers, and how they can work together on that as well. And we've seen this in the US as well. It does work.
And there is a point there, isn't there, about we're seeing in the US and globally some of the larger employers starting to think about creating their own healthcare systems rather than going through insurance. I'm really sorry, guys, but I'm afraid we've run over the time that we have for this segment, which is a great shame. So those of you in the audience who want to see more of this conversation, and I certainly want to see more of this conversation, Healthcare World Stage at Arab Health, please, in a couple of weeks' time. Apologies, guys, but we are going to have to move on, because waiting in the wings, we have the brilliant Jim Campbell from the Head of Workforce at the World Health Organization. Jodie, I'd also like to invite you to pop your camera back on and join in as a workforce expert in this conversation. Jim, great to see you. It feels like only yesterday that we had a really interesting conversation, doesn't it?
Hey, Steve.
And that's another plug, by the way. Yesterday I recorded the Health Beats podcast, which you can find on Apple Podcasts with Jim. That'll be available in a couple of weeks, and that was a really fascinating conversation. Jim, I mean, we've had some really interesting discussions over the course of this session already, and touched on some things that we talked about yesterday. One thing we didn't get the opportunity to talk about yesterday in a wide-ranging discussion about global workforce is that question of female leadership. Is female leadership, and indeed diversity in leadership in global healthcare, an issue or a concern to you from a WHO point of view, with that that sort of global policy lead on healthcare workforce hat on that you wear?
Absolutely, Steve, and fascinating to listen to Jodie earlier, also Graham, and some of that human capital thinking and value-based care. We look at it from a much larger labour perspective, and then in the context of the Sustainable Development Goals, the UN Commission on the Status of Women, March with Beijing, 30 years this year since the Beijing Declaration and Action Platform, big initiative in New York with member states and countries from all over around the world looking at where are we 30 years on, what actions need to be done. And they're looking at women in the economy, women in education, women in poverty, women in power and decision making, and women in health. And we need to connect the dots here, because if we're talking about economic empowerment, powerful roles, decision-making, and women and health, then we come back. It's not just about whether or not women can access the health services they need, but it's women as agents of change in the health and care economy. And if you take that industrial sector, Graham and others there, let's break it down into labor economics. If you take what is the economic classification of industries, human health and care activities. So we separate health and care, not just health care, the treatment, but health, human health and care. If you look at that, we have the economic sector around the world, we have the largest share of women, outperforming any other economic sector. And that's a very positive, but it's important then to look at how that is working. We look at the horizontal segregation of women in the health and care workforce. We also look at the vertical segregation. And what do I mean the difference? So horizontal, how many women are working as nurses and midwives, as pharmacists, as dentists, as physicians? Is there differences in each of these occupations among the health and care team, the care workforce? And we see huge variation. By country, by region, by income classification. Then we look at the vertical segregation, the leadership, and where are women in the pyramid of those occupations? How many women are taking up the leadership roles how many women are on boards, how many women are chief executives, and looking at this. So continuously looking at this, because what we see, Steve, is a gender value gap in the health and care economy. And we've published on this just last year around these issues. We see value gaps overall, but we see value gaps in leadership, we see value gaps in pay, we see value gaps in participation, and on and on and on. And these are detrimental to the overall performance and optimization of the economic sector.
So Jodie, I guess from your point of view, some fascinating insights from Jim there into the state of women in healthcare and women in the global economy. Do you want to just kind of react to that and maybe throw back any questions that you've got to Jim?
Well, as I wasn't prepared for this panel, but yes, of course. So just, I mean, Jim will obviously have more data than me, but I was just looking at some of the notes I had and saying, and McKinsey had done some research back in 2022 and just talking about the sort of gender parity. I'm just saying that if there was companies in the top quartile for gender diversity on exec teams were 25% more likely to have above average profitability than companies in the bottom. Companies with more than 30% female execs were more likely to outperform companies that don't. And talking about 12 trillion could be added to the global GDP if all countries match their best in region country for gender parity. You know, I think it is absolutely compelling. We know the economics behind it. We know that the progress that has been made, but there is more that can be done. And it is not going to be done overnight. I mean, I'm really fascinated by Generation Alpha. You know, Generation Alpha are those kids born, your daughter will be in it from 2010 to 2025. It is currently the largest generation in history. It's going to be the most diverse and the largest generation. And they have, you know, already we're seeing it through the research that's coming through, really different drivers. You know, they want equity. Health is listed as their fourth most important factor. There is going to be an increase in women in STEM industries. You know, and so what's that going to play out? How do we, for the future workforce, you know, encourage and create those opportunities where it's not, well, 4 in 5 women are in healthcare, but it's okay, you're a nurse. You know, they are going to actually, I hope, I've got 2 daughters, I hope they're going to play a really significant part and saying they want to be part of the decision making and driving those economic opportunities.
It's a really interesting point. I mean, we talked earlier on in the discussion with Jacqui about the generational change in Saudi and the change in Saudi attitudes over the last 10 years. And certainly my experience has been that has been driven by youth. It's been driven by the fact that you have a young economy, a lot of younger people who have travelled abroad to study, who've then brought back the attitudes and values and ideals around equality. And that's what's driving the change in Saudi Arabia. Jim, we talked yesterday, didn't we, about some of the economies around the world that have had high birth rates and high rates of growth over the last few years, and the fact that they will be the countries that provide our healthcare workforce in the near term, in the near to medium term. How important then, from your point of view, is this question that Jodie's talking about Generation Alpha in terms of driving the change, not just in gender balance in healthcare, but in the way that we do and deliver healthcare generally? Again, we talked about this in terms of some of the digital elements yesterday, didn't we?
Yep. So, I mean, the first point we look at, Steve, if you want to impact decent work, if you want to impact the health and care economy, then you start with the workforce that's there today first. That's where we're gonna, we want to see the greatest input and the greatest differences. And we've got, like we mentioned, all these different gender value gaps, which are pervasive around the world. low income, middle income, high income, Gulf countries, OECD countries, whichever classification you can do it, the differences. So there's an immediate opportunity to go in and work with the existing workforce, with the existing, and some of your other speakers were talking about the private sector growth. It's not just the personnel in the health facility, but it's the whole economy around these anchor institutions, the research and the development, the supply chain, the medical tourism, which may be there, the health insurance companies, the entirety of the economy as private sector grow in businesses and AI, intelligence, software. How do we look at all of the workforce and the industry to make sure that we're supporting them? Then we look at those that are coming into the workforce. And if we look at the student body of health professions around the world and their expectations and anticipation, the early career work is very different. And as Jody says, whether that's Gen Alpha or other demographic groupings, they are going to make a difference around some of these things. But we've got a lot we can be doing in the 30 years of history from the Beijing Declaration, a lot we can be doing immediately with the existing workforce. And that's where I would put the first dollar must go into those that are working today.
You bring the point up there about looking at the existing workforce. There are, of course, situations where there is a lack in the existing workforce or an aging workforce that means that countries need to go to the markets globally to bring in healthcare workers. We're talking about 50 years of Arab health here, and the Gulf countries in general have always been consumers of healthcare workers, bringing in healthcare workers as migrants from other parts of the world rather than being able to rely necessarily on their own populations. Some of that being down to the fact that some of these countries actually have quite small populations of indigenous population and quite large expatriate groups. How can those countries be good global citizens from a workforce point of view? How can they develop sustainable workforce models for their healthcare drivers?
Exactly, sustainable models, and there are differences around the world, as you say. Some of the Gulf states got a very completely different model and rapid acceleration, rapid economic development, creating jobs, creating wealth and opportunity there for global citizens to come and work in their jurisdictions. But we also look at how do you build your indigenous, your domestic population capacity for some of these roles, and that needs to be a balance. And if you recognize that you may not be able to do the domestic one at scale for a period of time, what's your responsible citizenship? How are you a responsible actor? How are you an ethical recruiter in the global labor market? And how do you value? Because just as with the economics of this, if a physician or a nurse, if a country X that's from Asia or Africa has invested taxpayers' money into their education, their competencies, their skills, their clinical experience, and then that is absorbed into a different jurisdiction for a zero cost. There's a transfer of economic resource here. There's a transfer of human capital investment. And so that responsibility to recognize that exchange has happened and to co-invest back into those countries, to co-invest into education capacity. And in a larger scale, Steve, if for the next decade, the next 20 years, you're going to be dependent on the global labor market, why not co-invest in an oversupply in that global labor market? It makes common sense if you want to expand a health economy, a health and care economy, that you're co-investing in the human capital. You can't just be absorbing human capital as a free good.
Jody, from your experience, of course, you work here in the UK, which is one of those, I think we talked about yesterday, the 10 countries that are the biggest consumers of global workforce. How do you see the UK in the respect of what Jim's talked about there? Is the UK a responsible global citizen in terms of the way that it works with the global labour market?
Well, I think particularly in healthcare, certainly there is a commitment to do that and very clear parameters around how they participate in that global workforce. recruitment and development. And certainly there are, some really good and quite inspiring examples of, if I think about the NHS, some of the NHS trusts who are doing this, and the sort of co-collaboration, the mutual benefits, and actually, what can we learn, particularly around some amazing primary care examples in other regions, in developing countries as well. I think there are huge mutual benefits that can be learnt. I think, the UK, there are other markets, and the Middle East is one of them, where are possibly in more competition with the UK in terms of attracting and retaining talent and international talent. I think more broadly, taking a step back, and all health systems, are having to look at this. And we've talked about AI, digitization, value-based healthcare. If we think about the Darzi recommendations that were done on the NHS review that he did, absolutely agree with Jim in terms of looking at the workforce that we have now, but what are the skills? Where are the skills gaps? How can we motivate, engage, and potentially retrain or build skills for that existing workforce as they adapt to more AI or digitization? And I think there's a real challenge and a tension at the moment in terms of, over 100,000 vacancies in the NHS. We know what the waiting list position is. We know that there is still impact post-COVID around burnout and exit. If I was somebody working on the front line, I'd probably be saying to my manager, I don't have time to learn how to operate this new fangled intervention. But I think actually the burning platform is such that we have to encourage organizations and individuals to play their part in driving that change. And it is the people on the ground who are going to drive that change.
And again, the point is there that as you talk about the younger people, the younger workforce coming through, that the use of digital technology amongst healthcare workers has to be a key part of the education and training that takes place for people coming into the workforce. Something that I'd like to get into in much more detail, but we haven't time, unfortunately, now. These segments are great, but unfortunately, they're quite short. Very quickly, Jim, you're going to be joining us at Arab Health. You're going to be on our panel talking about sustainable workforce in the Middle East. Over the course of the conversations that we have in Saudi first and then in Dubai, what do you think your key message will be to those health economies in terms of how they should be looking to really kind of make sure that they're doing the right things from a workforce point of view?
I would build on what Jacqui was saying earlier, and based on some of the other people who've got a lot more experience. There's a lot of very positive examples of change, of reform, of innovation coming further forward. And I would be inviting some of the Gulf states to also be innovators in the health work and the workforce space. Innovators around decent work opportunities, career development, lifelong learning, education, and AI and digitization. Innovation around public health. We've got to come back to prevention and promotion. As Graham was talking about, well-being has got to be the focus of human capital development. We're seeing West Streeting do the same. We've published on the sort of economics of health. We've published on the economics and the economic dividend that comes from investing in women in the health and care economy, for instance. So having that well-being agenda really as a core part of it, a combination of good public stewardship and real energetic private sector providers can drive some of these changes. And, good citizen of the world, absolutely critical. Gulf states, in terms of as they grow and as they get into a global labor market, how do you become a good citizen? We've got some excellent examples that we're already working with some of the Gulf states on, but we'd like to see a next level of engagement for a contemporary consensus and a future consensus.
Looking forward to continuing those conversations in the region in the next couple of weeks, Jim, and we'll see you there. Thanks, Jim. Thanks, Jodie, for your contributions. So our final segment today, and another area that we'll be talking about on the healthcare world stage, another area that I'm very passionate about, is the use of primary care and the various levers in different systems about how we use primary care. And to that end, I'd like to invite Dr. Samina Ahmed, Metin Forbes from M42 and the Fuller and Forbes Healthcare Group, NHS provider, to join me for this final segment. Firstly, guys, thank you for your patience, but I hope you've thoroughly enjoyed the conversation over the course of the last hour. I've certainly found it fascinating. But I think, primary care is a hugely important element, driver of all of these different things that we've talked about, because at the end of the day, you talk about value-based payer models, etc. Primary care is the thing at the coalface. Primary care is the thing that kind of works out how and where and what route into the system we take. But it's very, very different. And the reason why I'm particularly interested in having the two of you together on this, because there is, I think, for our audience to understand the differences between the way in which we engage with primary care in a private insured system like that of the UAE, of Abu Dhabi, of Dubai, as opposed to the way that we engage with primary care in a public system like the NHS, does mean that we're talking about quite different ways of delivering care. Samina, you've got a foot in both camps, haven't you, as somebody who's worked and continues to work as a GP in the UK, but also works in that system with M42. Could you reflect for us on the difference between primary care in the UK and in the UAE?
Well, thanks, Steve. So, we operate network of primary care centers in Abu Dhabi, and as I mentioned earlier on, when we're having an informal chat, that we have also worked for the NHS. So it's very interesting for me to see the differences between both the systems and to learn from both the systems as well. So when you look at the UK as opposed to the UK system, we in our clinics offer on-the-day appointments. 60% of our patients are acute patients who get the on-the-day appointments, which is a big number of appointments, and these are almost always exclusively face-to-face encounters. So straight on, you see, as opposed to the UK system, there's reduced waiting time to see a primary care physician on the day. Having adequate or good staffing level also ensures that we accept a large number of walk-ins. There's hardly anyone we ever turn back from our doors because we are so adequately and well staffed. We offer face-to-face appointments, and this also allows our patients to have greater access and greater choice in accessing primary care. Coming to referrals, even referrals to specialities on the day is pretty much straight away, as opposed to the NHS where we have a long waiting time. I think the average waiting time is now about 18 weeks, I think, to see a non-urgent referral. Last time I was in the UK, I heard even the 2-week referrals, cancer referrals are now taking slightly longer and not actually strictly meeting the 2-week criteria that they're supposed to. Whereas here, even non-urgent referrals are pretty much seen within a short span of time. The patients also have the liberty to choose a specialist of their choice. This offers, again, patient a greater flexibility and the choice to choose where they would like to have their specialist care. Similarly, follow-ups, blood tests, ultrasound reports, etc., all arranged within a very short period of time. The patient doesn't have to keep on waiting for ages. They don't have to call telephone for follow-ups or to arrange follow-ups. Simple procedures like blood pressure monitoring, etc., spirometries are all done pretty much on the same day or within 48 hours of seeing a primary care physician. So overall, these are stark differences which I see between the NHS system, primary care system, and the system in the UAE at the moment. I'm sure Metin will have something else to add on to that.
No, absolutely. So Metin, I suppose the first question there. When was the last time an NHS primary care clinic was able to see a walk-in patient? Somewhere around 1956?
That's actually a really good question, because actually back in 2014 at one of my other medical centres, we introduced a walk-in service, and we did a lot of research behind it. We've done research around walk-in services, and one of the things was they were often not linked to a specific capitated list. They were in a train station or at the front end of the hospital. And there were lots and lots of issues with it. So we wanted to try what a capitated system looked like. And in our community, we launched it Monday to Saturday, 8 a.m. to 4 p.m. And what we found was actually patient demand went down. And a lot of that had to do with the fact that people no longer worried about not getting an appointment. So they were more willing to give time to see whether their healthcare improved. And so our demand stayed flat at one point, even though we had gained an extra 3,000 patients in our capitated list. Interestingly, though, we then did the same thing at another medical centre in Leeds, and the results were completely the opposite. Demand went through the roof, and after about 3 months, all the partners gave up and said, we can't do this anymore, it's unsustainable. And so there was a whole component around the local population, deprivation, some of the social determinants. And yeah, it was a really interesting experience.
I guess, I mean, that's one interesting example with two completely different outcomes. I guess for me, the question is, why is it, you know, at a very, very basic and very simplistic level, why is it easy to get a primary care appointment in Abu Dhabi, but almost impossible to get a primary care appointment in the UK? Is this because we have a fundamental difference between how a free appointment delivery system treats primary care and how a private insurance system treats primary care? What's your view?
Well, I think that goes to the heart of it, really. I mean, the way the system works in the UK is it's a capitated system. So all of our medical centres have responsibility for most of the patients within their geographical boundary. And every single patient in the UK has the right to be part of a medical centre. And then so what that means is essentially it's free at the point of need or free at the point of want is quite often the case. And I think that's really leading to the NHS remit about wanting to ensure equity of access. But of course, the other side of equity of access is whether it's actually possible for the capacity to ever meet demand. And one of the interesting things that I saw when we did some visits to the United States is when you're looking at health outcomes within the NHS, you're looking at the whole population, whereas a lot of the insurers that we looked at in America, they were not looking at the whole population. They were looking at only those where they provided the insurance cover. And so it was like comparing apples to oranges. And I remember, for example, visiting Kaiser Permanente headquarters, and at the very foot of their building was this enormous homeless camp where people didn't have access to healthcare. Whereas in the UK, anyone that sets foot on British soil has access and has the right to free primary care. And I think on the one hand, that's an excellent system. But as we found over the last couple of decades, it has its enormous problems as well, which is overutilization.
And that's a key point. I mean, how you encounter primary care and what rights you have around primary care are hugely important. And I'll come back to you, Samina, on that one. You know, I don't know whether this is the case with M42 or with the insurers that you work with, but certainly in some of the insurance-led systems that I've encountered, there are disincentives to use primary care from the perspective of, you know, if I go and see one of Methven's GPs and there's nothing wrong with me, the answer to my query is go home, lie on the sofa, take a couple of paracetamol. That's fine. Whereas in insurance-led systems, if I'm coming in for an appointment and it's unnecessary, I might find myself with a bill. Is that the case in your economy? Yeah, are people incentivized and encouraged and able to use primary care freely in that way that Methven described in the UK?
Yeah, I mean, I'm talking about UAE, so there's no straightforward answer to it, I think, Steve. I mean, there are a number of reasons. You questioned this earlier on as well. You said, what are the advantages and disadvantages? If we summarize quickly, I mean, I don't get a short time here. It's a big, vast topic, to be honest. But and I don't think there's no clear answer to it. But if you look at the pros of it, yes, there is reduced waiting times for primary and accessing specialist care in the UAE, and it allows you ease of access to specialist care. It allows you more focused specialist care, eases the pressure on primary care facilities. But then you've got the cons to it as well, which number one would be the non-universal coverage, which we spoke about earlier on. If you walk into the UK, you sort of granted access to healthcare irrespective of your age, your color, your background, your insurance, whatever. Yeah, it's an insurance-based system. So when you walk into a center, the first thing is going to be checked is you do have coverage to access medical care in that center. So that obviously is a big con that it's not a non-universal coverage there. Secondly, the Middle East, lower primary care engagement often results in over-reliance on specialists in emergency care, which again is more expensive. It's less efficient, and it leads to poor clinical outcomes. So if you look at the UK, you have high levels of primary care engagement. Yes, it's difficult to get appointments, but you have a robust system there. There's early emphasis on better prevention, early diagnosis, better patient management leads to better management of chronic conditions, reduces hospital admissions and overall health cost. Yeah, in the Middle East, this access to specialist care or less engagement with the primary care leads to more fragmented care. It's worse health outcomes, especially for chronic disease management. Again, there's over referrals, there's over investigation. As said, you go in and you come out with a hefty bill. So that can happen. So where there are a lot of pros, but there are also quite significant cons to this sort of a system.
And historically as well, there's been an attitude, certainly in some countries of the Middle East, that primary care general practitioners are not proper doctors. Certainly there used to be a sort of standing joke about, what do you do if you've got a headache in the Arab world? You go and see a brain surgeon. Has that changed? Are the population changing their attitude towards primary care, and are they now happy to engage with it? Or is there still that feeling that, no, I need to go and see a specialist?
It's a mindset. It's changing. I mean, we've progressed. I've been in the UAE now for about 9 years. And I've seen that change, a subtle change. It's happening. The Department of Health is placing more emphasis. It's part of their strategy for the Emirate, to move towards a primary care system. So they're investing in it. So it will take time. It needs patient engagement, education. It's not where it should be, but it's certainly moving in that direction. Is that what I would say? And you're right. It's patient perception as well, that your primary care provider is actually competent, is qualified. Jack of all trades, but there to treat almost everything for you.
And Methven, I think there's another point here, isn't there, about what do we mean by primary care? I mean, certainly in the UK, there's talk about certain levels of cancer treatment being provided through primary care. There's talk about the degrees to which mental health is provided through primary care. One of my favourite examples of a very good friend of mine who's a general practitioner in a rural practice. He talks about a lady who comes in for an appointment every Thursday at 11 o'clock with a different complaint, when her real complaint is that she's elderly and lonely and wants somebody to talk to. So, is there an issue here about how we define what we mean by primary care?
I think that for me goes to the very heart of the current issue within England, within the United Kingdom, is that actually general practice or primary care is the catch-all for everything. So you've got a population with very complex needs, some that are medical, some that are non-medical, social determinants, and primary care is on the receiving end of almost all of that. And I think that has grown over time. When GPs used to respond to urgent needs, and then it grew to long-term conditions management, and then our workforce grew and grew to accommodate more and more. Over the last decade or 2 decades, actually, they've also had GPs involved in commissioning and fund holding and community services. And I think what eventually happens is you have medical centres that were very, very good at doing a set number of things, but the more you stretch that to try and cover all bases, then eventually it does everything relatively mediocrely. And I think for us, certainly when we compare across all of our medical centres, you see that, it's not just NHS England Central that's commissioning. There's local commissioners, there's council commissioners, and there's lots of other commissioners where if there's a need that comes up, or an issue, or maybe an idea, great, we'll commission general practice to do it. And so therefore you have this whole industry within medical centres where we're having to manage all of that variability and try and spread that workforce out and train people up to do as much as possible. but it's not sustainable. And we end up moving away from what core general practice is, which is why in the news often these days you hear, I can't get an appointment to my GPs. I mean, I did an audit across all of our medical centres, and I would reckon that maybe 70% of all of our appointments need to be reserved in some way because of all of the proactive, preventative follow-ups, targets that we've got to meet. So it leaves a small proportion for what people perceive to be general practice, which is, I feel ill, I need to see someone.
Which interestingly is the counterpoint to take back to Samina, which is, in the UK, in a free at the point of delivery system, the GP is the catch-all, is the do everything, is the, if we have a healthcare problem that we want to deal with, throw it at primary care. And the preventative agenda is one of the elements that comes into that. And yet, Samina, I guess in a Middle Eastern system, one of the issues, unless you can promote greater engagement with primary care, is actually how many conditions, how many issues are we not going to be able to prevent? Are we going to miss? How much public health messaging around diet, smoking cessation, etc., are we unable to deliver if we aren't seeing that volume of patients coming through the door? Is that the right way of looking at things?
I think so. I think you summarized it quite well, Steve. I think we need to create awareness about the importance and advantages of having a robust primary care system in the Middle East, change the mindset, get better patient engagement. And as I said, there's no one answer to it, but it's a multi-pronged sort of approach, getting patient flexible models, telemedicine, bringing primary care through AI measures, smart clinics, for remote areas, and encouraging patient trust in the primary care provider. I think that's very important. The more they trust you, the more they have that rapport with you, the more they would engage with you as well.
And I think the important thing here is we look at the two of you together is how much you can learn from each other and how much collaboration opportunity there is between the two countries. We're out of time, unfortunately, which is a huge shame because, again, so much more to talk about here, and we will be debating this topic in more detail on the Healthcare World stage. I think that point around collaboration is a great place to leave this, because Arab Health, the 50th Arab Health, you look back over all of those events in Dubai over the years and you wonder how many international collaborations started at events like Arab Health and how many more will start at this year's Arab Health, where I and the majority of the speakers that we've had here today will be appearing on stage to continue these discussions and debates in more detail. Register to get onto the Healthcare World stage. Go onto the Healthcare World website, www.healthcareworld.com. Look us up on LinkedIn. You'll be able to find details of how you register for the Healthcare World stage there. And we'll see you in Dubai. Really, really looking forward to it. Really, thank you again to all of my panelists, to Samina, to Methven, to Graham, to Jodie, to Rob, to Jacqui, and of course to Jim. I think I've name checked everybody there. Thank you also for watching. There'll be another Healthcare World series along very soon. But in the meantime, if you're not already coming to Dubai for the 50th Arab Health, why aren't you? Go and book a flight. We'll see you there. Thanks very much. Goodbye.